Hi, I'm Dr. Joanna Thirsk, and I am a dual trainee in anaesthetics and intensive care in Aberdeen. I have interests in expedition medicine as well as paediatric critical care.
Hi, I'm Dr. Kirsty and I'm currently in FY2 in ICU. I'm just about to finish up 4 months there. In my FY1, I did my FIY on a COVID ward. I then worked on geriatrics. I spent some time up in Rigmore doing Gen Med in AMIA, and then I finished up in paediatrics. I think first of all would have been advanced life support. I was really lucky to do that course a month into intensive care, and I think that made a huge difference, just from managing like out of hospital cardiac arrest to arrhythmias to even managing an arrest. It was really useful. I think secondly would be respiratory physiology. I think that forms kind of the backbone of all ICU management, especially when it comes to level 3 patients, and it can really help you understand why they make changes to a patient's management, and also kind of introduces you into how to ventilate a patient. And I think the third thing would be stamina. The days are long, but luckily if you've got lots of snacks and you've got colleagues doing coffee runs that get you through it, but I think you have to be aware that it is a 24-hour service and all the shifts can be quite full on.
Coming to ICU is a really big adjustment for anyone, whatever your stage of training. It's a whole new world of monitors and machines and new physiological concepts. One piece of advice I would give is to buddy up with a nurse on a day or a night shift. I think that would just give a junior the edge in terms of knowing how the machines work and feeling a bit more comfortable around the bedside with the different monitors. And there's loads that we can learn from our nursing colleagues. Second piece of advice would be use your phone, download some cool apps, look online. There's a whole host of social media that's out there. It's useless looking through long and lengthy textbooks. Information is always constantly changing, so to stay up to date, there's multiple suggestions that I would give a junior for apps. Thirdly, I would say don't put too much pressure on yourself. Try and get rest in between shifts. Focus on your external life, which is just as important as your work life, and don't stress that you don't know it all. A good junior to me is someone that knows their patient and that uses a systematic approach to their examination and management. And if you are just able to do the simple things well, then you're flying through.
I think the main difference is that when a patient does come up, they do tend to be quite unwell. So I think firstly you have to really deal with stabilising the patient. So that might be firstly helping the nursing colleagues to get them settled in the bed, to work out straight away what needs to be done before you pick up the notes and kind of go away and start typing. It might be that it's really important they have their art line put in first so that we can see what their blood pressure is. It might also mean that they need to get started on some vasoactive medication straight away. So I think normally in an AMIA ward you can take a wee bit of time, reading up about the patient, getting to know them. You might even start typing up some of your clerking, but I think in critical care it's really important first of all that you make sure that the patient's stable and the nursing team are happy with what the initial plan is. So I think the first thing is you always get your handover from your colleagues, so you're always aware any changes that happen with that patient in the night. I find it's really useful to do kind of your initial assessment as in their issues and try and separate them from that being, if airway's been an issue, to have they got any electrolyte abnormalities, kind of creating points in your head of the separate matters that affect the patient. I think when it comes to examination, it's really important to start with their airway, and that'll include, what their ventilator settings are, how have they changed in the last 24 hours, and then you can kind of move on and work it through system by system.
Yeah, and I think that's really important. A lot of people come through to ICU thinking they need to know all the complicated things, but it's really, as I said before, just knowing your patient, because that will be appreciated by your seniors who may be rushing around reviewing patients in other parts of the hospital. So if they feel you have a good handle on what the current up-to-date numbers are in terms of their bloods or what their current ventilator settings are, then just having that information to hand would give me confidence that you were on top of things.
And I think off of that, what you're saying about bloods and scans, unlike other wards, a lot of our patients do have daily bloods and they will have outstanding scans. It's really useful if you can make sure you've checked the bloods, you've seen the imaging, and just again, because your kind of more senior colleagues will be looking after multiple patients, and it's good to say, oh, I've definitely seen that x-ray and it's safe to go ahead.
And it's the small things that often get missed. You know, if someone hasn't spotted a small pneumothorax on an x-ray or a misplaced ET tube, then those kind of things you can flag up, or blood results. So I think that's really important, and you can go a long way with just knowing your patient well.
I think also the kind of safety net when you do see the patient is to always check in with their bedside nurse. You'll always know that the kind of main issues of the patient, and it's good because sometimes they'll pick up on things that you might have missed, which can be really useful. Yeah,
it's a multidisciplinary team approach, which you may not have in other areas of the hospital. So we all rely on each other to be eyes and ears, so that mistakes can be picked up. And there's a really flattened hierarchy in ICU, and certainly you know, the nurses are not afraid to speak up and tell us what they think as well. So just appreciate their long experience that they've had in ICU, and what worries a nurse should worry us as well. Any chest x-ray, an ABCD approach always comes in handy with everything in ICU, looking at your airway, your lungs, your heart shadows. And then it's really important to make sure that lines and tubes are in the right place. There can be serious complications if not, and often these things get overlooked. And there's so many you know, different tubes, different lines that might be in a patient. NG tube, especially important to make sure that that's correctly sited. So yeah, sometimes it can be confusing. You might not know what things are, so just don't be afraid to ask.
So our day normally starts at 7:30. We get a handover from our night shift colleagues. We'll go through all the patients and kind of what their update is from overnight. You'll then be allocated normally about 3 or 4 patients, just depending on how busy the unit is and what the staffing levels are like. And they'll be your patients for the day. So you'll do their morning review. So that'll include their kind of update from overnight, their A to E head to toe assessment. You'll then look at their medications, look at their lab results and any outstanding scans. You'll then go and see your patients. You'll examine them individually, and then you'll make sure that you're ready for the morning ward round. That normally starts about 9:30. You'll then go round with a consultant and a few other colleagues, and it is very much like old school Grey's Anatomy style ward rounds. You know, you'll be quizzed on your patients, but it's always with positive encouragement. You know, I think that's the biggest thing about critical care. You will be asked questions, but it's all to develop your learning, and they're never expecting you to have every answer, but to have a really good attitude to develop your learning, and I think that's been the biggest learning point. The day then normally has a bit of a coffee break, if appropriate, and we'll do a microbiology ward round. So we're really lucky that our microbiology colleagues will actually come every day and review every patient. We'll look at all their antibiotics and their latest blood cultures. You'll then spend the afternoon doing off all your patients' jobs, so that's if lines are needing changed or scans need requested, and then you'll have an evening ward round that will normally be about 4 o'clock. Again, you'll go round all the patients and you'll make plans for them overnight. After that, you'll update their families, and I think that's a really kind of different moment about critical care. You really do build strong relationships with the families, and those,
especially during COVID, making it so much harder with updating
when they
remotely.
can't visit. And I think we've really combated that well with, you know, the kind of iPad use that the patients and the bedside nurses use. But I think it really makes you realise how important that daily phone call is for families. After that, there might be a few more jobs that need to be done, and then about 7:30 you'll be handing over again to your night colleagues.
And I think that sounds like a really busy day, isn't it? And there's a lot of things to do. It's really important to prioritise most important jobs first, especially if you're going to be extubating a patient, to get that done earlier in the day rather than later, and anything that might need acting on, to get scans done early on, so that you have a chance to intervene and manage those appropriately depending on what's found. So I think as a junior, prioritization really comes into play in ICU.
Definitely, and then off of that you're also aware of any new patients that might be coming to the unit, and when they arrive, they'll need clerked in, and they'll also need any outstanding jobs done. So the day is really busy, but the days are definitely filled with lots of learning, and it'll probably be the first time that you'll actually come across some conditions, so they're certainly never boring.
No, and also one must remember that it is a shift, and at the end of your shift you can hand over jobs. It's an ongoing 24/7 care process, so don't be afraid to hand over to your colleagues, and certainly try and get home on time.
So one of the things I've really learned is about CT scans. So I think when I've worked on any other ward, you book a CT scan and one of the porters kindly turns up to take your patient down, but things work a little bit differently in critical care, especially when we're thinking of our level 3 patients. They're intubated and they're ventilated, and they need to be...
especially if they're on ECMO.
Definitely,
yeah.
That takes a lot of staff to make sure that that's safe for them to go down to CT. So when you were saying before about how you organise your day, something like a CT scan is something you'd really want to make sure you phone for first in the morning. You'll get a time from the CT department of when suits them, and then you really need to make sure that you've got someone airway trained with you, and you've got the appropriate people to transport the patient safely.
Yeah. And making sure the patient is optimised prior to that, because all too often you're called to scan and the patient's suddenly acutely deteriorating, and you need to get on top of things, and then you're late for the scan and everyone gets grumpy. So just trying to preempt that as much as you can. It's often not avoidable, but certainly just make sure that your patient's in tip-top condition for the journey, I guess. So loads of different machines, and really I think that's, as I mentioned earlier, invaluable to spend a shift with the nurses getting to know the machines. So I think ventilation would be the one that's most important to get a handle on. And if you can just take someone aside, registrar, one of the A&Ps, a senior nurse, they can really talk you through just the basics. And don't get your head too wrapped up around all the complicated concepts. Just try and get attuned to your basic settings, your respiratory rate, your PEEP, your FiO2, pressures versus volume ventilation. Just simple concepts at first, and then you can build slowly from there. And there are a host of online resources and tutorials that you can work through. Then you'll also find your renal replacement machines, and it's good to have a look through what those do. I think with a nurse is probably the best way to do that. And then in your spare time you can read up some concepts. We're also lucky in Aberdeen to have renal physicians that work in our ward, and if you take one of them aside, I'm sure they'll be more than happy to talk you through how to prescribe your renal replacement therapy and what our aims are when we are doing renal replacement. So those will probably be your two biggest machines that you're going to find. But in addition, it's the smaller stuff like the infusion pumps. Now, you come into ICU and you just feel all a bit helpless when you come to a patient and they're flailing around in the bed and someone says, please can you bolus some propofol, and you go, oh my god, I don't even know how to give a simple medication bolus. And it's really helpful if you can just get your head around how to change the pump settings, give a bolus, so that you can be helpful in a situation where your patient's about to self-extubate and needs to be resedated. And then of course your monitors, you may think that's a simple thing, but really just knowing how to turn off the alarm on a monitor might be an important thing to do. How to set up an arterial line, for instance, and zero your outline, zero your CVCs, small things like that, which you often don't get taught that ever. It's kind of something you have to figure out. All the sedatives, really important, so things like propofol, ketamine, also a very useful drug as an induction agent, and obviously your opioids, real staple in terms of our sedation. After that, I think importantly, it's your vasoactive drugs, your inotropes and your vasopressors. So if you can read up a bit about noradrenaline and adrenaline, which are our mainstay of drugs in adult ICU, then that would go a long way towards helping things. Also, antimicrobials. So sepsis is a real big concern in ICU, ventilator-acquired pneumonias, CVC infections, and I know we rely on microbiology a lot to tell us what to do, but if you can get a grip on what local guidelines are in your ICU, then that's really helpful.
I think the only one is managing delirium, probably because that's one thing we do very differently in critical care. So understanding how we use quetiapine at different doses and how we adjust that in terms of a patient's response is also one of the things that's quite new for a junior to get their head around.
Yeah, definitely. No, that's a really important point, Kirsty. I'm glad you mentioned that.
Before you know it, you'll be calling things like Alfie by the end of it, sounding like you always knew what that was.
Yeah, exactly.
I think definitely an arterial line. I think when you first come in you think, oh, I would love to know how to do that, but I think that's probably one of the first kind of lines that you will get the chance to learn when you're in critical care. And I think when you're just starting out, you're a wee bit nervous, it's quite good if you know the steps that are coming up. I also think looking at ultrasound guided procedures, so even just if you can get your head around how ultrasound actually works, if you watch one of the videos on how to use the probe, that can be really useful. And I found learning how to use ultrasound has been invaluable, not only for central lines but for things like difficult cannulas going forward.
And really useful for when you're out of ICU, that you can take those skills.
Yeah, and I think kind of becoming really line competent and then being able to advance that is one of the skills that, even if you don't want to do critical care in the future, is invaluable for when you do step onto the wards.
Yeah, I think ultrasonography is really evolving, and it's going to become one of the big mainstays of how we investigate our patients. So if you can get your head around a few of those concepts and maybe even do a basic course, then that's also going to be really useful to take forward. Also using a defibrillator, for instance, get to know the defibrillator that's on the unit, so that you can use that in an emergency, especially synchronized cardioversion.
I'm obviously one of the juniors, but being junior means that you're working with a whole breadth of people from different backgrounds. So I'm one of only 2 FY2s. The rest are made up of surgical trainees, so they'll be doing their 3 months of critical care, as well as some IMT trainees. So both of those people come from different backgrounds and they have different approaches as to how they manage patients. We've also got some of our anaesthetic trainee colleagues, so it's really useful because although they are on a junior rota, they are airway trained, which is really useful.
Everyone kind of says, oh, they're airway trained, but just remember your important skills as a junior will be that you actually know a lot more about how the hospital works than a lot of the anaesthetic trainees. So you can really use that to your advantage. And the further away you go from your FY years and your medical student years, the less you know about how to order things and how hospitals work and the organizational aspects. So despite the kind of higher level skills that you will see in your colleagues, I think it's always important to know that you've definitely got the upper hand when it comes to using the computers and ordering investigations.
You know the porter's number.
Yes, exactly. So we have a very different patient population on intensive care, a wide variety of ages, different physiologies. Certainly knowing about your aims for your patients is important. And we've got a much closer monitoring or an eye on things that go wrong. So we can tolerate abnormal physiology that might be very deranged on a normal ward where you were not looking at things really closely. So it's important to remember that as well and try and get your head around those concepts. I'm happy to be called about anything. I'd rather know earlier what was worrying any of my colleagues. I would like a patient to be escalated early on. I think one of the things that you need to get your head around, specifically if you are a doctor on the wards, handing over a patient or referring a patient to ICU is how to do a good referral, and that sounds easily done, but it's really one of the hardest concepts to learn. What information does that person want? And really it comes down once again to our ABCDEs and having a very systematic approach to the patient and highlighting what the concerns are. I think that's really important. Nothing is too silly. When you come into ICU, it's a totally foreign environment. You've never experienced anything like that before, and I can understand people would feel intimidated, and that's totally reasonable. So no question is stupid whatsoever.
So I think there are 3 things, Jo, that I would definitely learn for a ward round, and that would be the Krebs cycle, Fick's law, and what is a base excess.
Excellent. Yeah, an oxygen delivery equation as well, really important one, useful. Also, get your head around fluid balance and what you're aiming for on the machine. Steroids, that's always very topical, and your head trauma trials as well. Yeah, where we get our evidence from. A really useful app is the ICU Trials app, which I've downloaded on my phone. You can regularly update it and it comes up with the top ICU trials. So you can just flick onto that and get the headlines. Also online, the bottom line, that gives us really nice summary of the latest trials, and I'd really advise having a look at that.
I mean, you can be a herbal tea drinker, but I think that'll raise some questions. But if I'm honest, I think if you're not a coffee fan, you'll become one because you need it. The days are long.
That is very true.
And it's a good way to like bond with consultants.
I wasn't the coffee fan, and yeah,
look at you now.
It kept me going through a lot of long shifts.
I think as a junior Jo coming to critical care, I probably didn't appreciate how difficult some of the situations are that you experience. You know, we are critical care, but we do experience quite a lot of patient death. And I think it's really important that you are able to manage that and you can kind of be debriefed from that appropriately. Where our work has a really good system that we have a weekly morbidity and mortality meeting. That's really useful because you can hear consultants' reasons for their decisions and how that case was managed with it, which I think really helps with your own kind of mental health and accepting what's happened to some patients.
Yeah, and definitely just your decompression in the coffee room with your colleagues. Don't underestimate the power of that as well. Just talking through things after they've happened is just really, really useful. It's really important to keep that work-life balance. I know it's said over and over again, but I can't emphasize it enough.
Oh, totally. You cannot be a post-night's brunch after a busy weekend shift.
Exactly.